This is the January 30th, 2019 Health and Hospital Committee Special Meeting, 2 p.m.
Will do, but we'll try and let you know a little bit more about what I'm hoping to get from you, so that when you come, right, we're not having just a chit chat. All right, ladies and gentlemen, thank you very much. If we could ask that the chambers please come to order, and we'll begin today's meeting of our Health and Hospital Committee with item number 1, the call to order, and ask the clerk to call the roll and establish the presence of a quorum.
Chairperson Simidian,
Here.
Vice Chairperson Ellenberg, Dr. Smith. Excuse me, we have a quorum.
Thank you.
Yeah.
For the record, Dr. Smith isn't a voting member of the committee. Nor does he wish to be, I think. Thank you very much.
No, I pass on that.
Thank you. Before we get to public comment here in just a minute, I do want to first express appreciation to former Supervisor Ken Yeager, who chaired this committee for the past 6 years. I was not able to be here at our last committee hearing and his last meeting as chair, but would have added my well wishes and thanks. Also, of course, want to welcome Supervisor Ellenberg to the committee. Looking forward to working with you on this. And I should perhaps share that over the course of the coming year, I'm hoping that this committee will be slightly restructured and a venue for departments and staff, as well as members of the public, obviously, to raise issues that need board attention, and to use this committee venue as a place where we can work collaboratively to have those conversations and to move towards shared goals. That's going to require a little restructuring. That's going to be a bit of a work in progress over the next few months, so I hope you'll bear with us, but I think certainly by the time we get through March, we'll sort of say this is what it looks like, and here's how we're going to structure things. But I sort of want to let everybody know that that's in the offing. Some of that you'll see today. And frankly, I'm hoping that we use our committee meetings almost as mini study sessions, if you will, so that we really can delve a little more deeply. And also, and I'm just going to be blunt about it, sort of do away with some of the make-work reports that I feel have, frankly, taken up a lot of our time at the expense of more sort of a in-depth conversation about important pending issues. Before we go on, though, I want to go to public comment, ask the clerk, do we have cards for members of the public who would like to speak under public comment? Apparently we do. Thank you very much. And for those of you who are unfamiliar with our process here, public comment is that portion of our agenda set aside for comment by members of the public on non-agendized items, but properly within the jurisdiction of this committee. And we allow up to 3 minutes for public comment. So I will call up Leonard Williams, Lorraine, is it Zeller? And Mario, I believe it's Gonzalez. So if you'll come on up and share your thinking with us. Welcome. Leonard Williams, then Lorraine Zeller, then... We are speaking to Mario Gonzalez is speaking to item 6E. Forgive me. That is noted. I just got them handed all to me for public comment and didn't note the distinction. My apologies. But Leonard Williams is making his way forward, and we want to welcome him. Mr. Williams, come on up.
Good afternoon and belated Happy New Year. My name is Leonard Williams. I'm a PFAT member and ambassador for Valley Medical Center, and I'm here to speak on behalf of all the people that are volunteers and let you know that for 3 years I've come here, and you've all noticed that I've always been positive, always ha-ha, happy, happy. Well, one time I came in here and I was very upset, and it wasn't because we don't have problems at Valley Med, because we do. My whole theory is I belong to PFAT. I'm the ambassador. We have a bunch of teams. We meet once a month. A lot of the issues that come up are solved within our PFAT organization. They are brought up by the patients, which we love. We are given the problems. They are sent up to staff. Staff gets back with us with whatever problems there are. So therefore, that's why you don't hear me come in here and say, well, this is wrong, that's wrong, because almost all of the problems we have are solved within house. So we have a great staff. We have a staff that really supports, and believe me, supports PFAT. You don't know how much support we get. If you could only come to one of our meetings and see what we go through, the staff that comes there when we ask for something, They're not afraid to give us an answer, whether it's approved or not. So I just want to let you know that, yeah, we have problems at VMC, and we will always have problems. But when we can solve them at the lower level, at the PFAT level, working with the great staff we have, then that's what we're going to do, and that's what I intend to keep doing, and that's why you're not going to hear me say a lot of bad things about VMC.
Okay. Thank you, Mr. Ambassador. And if it's Lorraine?
Yes, but I stand corrected. I'm new at this. Actually, my comment is under item 5.
Thank you. And it does say new, item number 5, so I think I'm the one who's new at this, so bear with us. Thank you. All right. I don't think we have any other cards that are actually for this item number 2, public comment. Yes, no, maybe? And that's also for item number 6, so we'll get to it at that time. Thank you very much. That means we've dispensed with item number 2. We're going to go to item number 3, which is to approve the consent calendar and any changes to the committee agenda. Supervisor Ellenberg, I'm going to ask if I can get a motion to approve the consent calendar, which is listed as items number 8 through 13, but I'm advised that that could actually be item 7 through 13, if that's agreeable to you.
Before I make the motion, I think that it may be appropriate for me to not approve the minutes for the November and December meetings, since I wasn't part of those meetings.
I'm going to implore you to approve the minutes because, absent 2 votes on our 2-member committee, we do not have a majority of the committee voting present and active. So
then I shall trust that you'll tell me that the minutes are accurate.
The minutes are accurate, and I'm going to exhort your participation on
Therefore,
that.
I will move to approve the consent calendar.
Thank you for that. I appreciate it. County Council is always honest about that in a good way. So items 7 through 13, a motion by Ellenberg, second by Semidian, without objection, and hearing none, unanimously approved. Thank you. All right, now we get to the heart of our business, item number 4, and this, of course, is a monthly item that we take up, is to consider recommendations relating to the medical staff at Santa Clara Valley Medical Center. So if you'll introduce yourself for the committee and members of the public.
Hi, good afternoon, Board of Supervisors and members of the committee. My name is Yvonne Karanis, and I'm the president of the medical staff at Santa Clara Valley Medical Center. I'm here to present our credentialing report and answer any questions that you might have.
All right, thank you. We have that under item number 4, and as I say, this is an important but relatively routine item, so if we can get a motion to approve.
So moved.
Thank you. And that is the recommended action contained in our published agenda as packet item number 4. We have a motion by Ellenberg, a second by Semidian. There is no discussion, and without objection, hearing none, approved. Thank you.
Thank you.
Well done. That takes us to item number 5, which is to receive the report from the Behavioral Health Services Department relating to County Medical Health Services Act programs. And I believe we're going to look to Ms. Tullies to walk us through this. And Ms. Tullies, my hope is that your initial presentation will take 10 minutes while you're looking for the clicker. Does that sound okay? And that then we'll have some real conversation. And you know, this is, those of you who are veterans know this, it's hard to have a real conversation at a committee meeting, but we're going to try, see if we can make that work. So if that means it's a little interactive, if that means somebody politely interrupts to say, excuse me, I've got a question, that's fine. And so we'll leave our mics live, and we'll look to you, though, to start us down the conversation.
So what we thought we would start with, pardon me, is a presentation that Tess Tiong, our team is sitting right here, and Tess, why don't you introduce yourself? Virginia, why don't you introduce yourself to the board members? And go ahead. This is a first. That's okay. Go ahead, Tess.
Hi, good afternoon. I'm here to present some financial data and update on MHSA. And just to give an overview, the California voters passed Proposition 63. A lot of us know about that. It's also known as the Mental Health Services Act. That was way back in November 2004 to expand, and the purpose is to expand and improve public mental health services. Now, although it was actually passed in 2004, in our county, we implemented that in 2006. The source of funding for this is the 1% additional tax on income above $1 million. So sometimes we refer to it also as the millionaire's tax. Now, the MHSA funding consists of 5 components, and each has its distinct requirements. Community services and supports, which is for direct services to individuals with severe mental illness, prevention and early intervention for providing funds, which provides funds to recognize early signs of mental illness and to improve early access to services and programs, including the reduction of stigma and discrimination. Innovation funding is distinct for the purpose of evaluating new approaches that increase access to the unserved and or underserved communities. And this component requires state approval. There's also the one-time funding that counties actually may continue to fund from CSS contribution. The Capital Facilities and Technology Needs Funding, which provides funds for building projects and increasing technological capacity to improve mental illness service delivery. Then there's the Workforce Education and Training Funds to improve and build the capacity of the mental health workforce. We don't currently receive separate allocation for these 2 funds, but as noted there, we may continue to use fund from the CSS distribution for these 2 purposes. The next slide presents the statewide MHSA component funding and estimates. So in FY16, the total was $1.3 billion, and the breakdown is there across CSS, PEI, and innovation. I'm not going to go into that detail. For fiscal year 17, a total of $1.8 billion, which is an increase of 34% from FY16. In FY18, $2 billion, a decrease of 10%. And then in FY19, in current year, we're estimating the state is estimating $1.7 billion, which is a slight decrease of 12%. In FY20, where the state is projecting a slight increase from the current year's estimate by 7%, which is around $1.9 billion in total for the state. Now, for the Santa Clara County, so translating it to what the funds are for our county, in FY16, the total was $65.7 million, I'm sorry. In FY17, $83.4 million. FY18, $91.1 million. And then for FY19 and FY20, what we did was we estimated it just consistent with the trend that the state has used in their estimates. So we're estimating $80.5 million in current year, and in FY20, $86.2 million. Now, the total funding distribution, the state really regulates how we distribute the total funds across the 3 main components, CSS, PI, and innovation. We are required to use 76% for CSS, 19% for PEI, and 5% for innovation projects. In these estimates, we haven't really incorporated the impact of the recently approved Proposition 2. We've reached out to a consultant for the state to give us more, to give us some estimates on that, but we haven't really gotten any firm numbers from them. The next slide is the Santa Clara County MHSA expenditures in the last 3 fiscal years and estimates for current year and FY20. So the total expenditures in fiscal year 16 was $64.5 million. Fiscal year 17, $80.9 million. Fiscal year 18, $84.1 million. And we are estimating $109.9 million for current year, and in FY20, $144.8 million. The unspent balance is indicated there. In FY16, we had 115.7 million unspent. In FY17, 119.4, and in FY18, 129 million. Now, these unspent balances actually includes interest that are earned because all funds, MHSA funds, are actually deposited in interest-earning funds. So we have trust fund for each of these components. So that includes interest. It's probably roughly about $3 million.
Let me ask you to pause here for a minute, if you would, please. And I apologize, I did not get your last name.
I was going to say.
My last name is Tiong.
Thank you, Ms. Tiong.
T-I-O-N-G.
If I mispronounce, please correct me. And Ms. Tiong, if you could go back a slide, please. And here's my first question, just so I understand the numbers. And Supervisor Lundberg, feel free to chime in at any point if you like. So if 76% of the total funding goes to CSS and 19% to PEI and 5% to INN, I think if I add those numbers up, that gets me to 100%. But if I go to the next slide, there are two other categories that somehow get funded. And I'm wondering where that money comes from if 100% of the money, according to this chart, goes to, I know there's an answer, I'm looking to figure out how this works.
So on the next slide, the funds, the expenditures were funded for wet and capital facilities technology. The expenditures were actually funded still from unspent prior years funding. And so that's why you don't see that in the current allocation. We've received allocation for this way back probably 2010 and 2011. And since then, the state has not released any allocation for this, although they do allow counties to use funds from CSS.
May I chime in,
Please.
Supervisor? So I think the thing that's important to understand, and Tess Tiong, I wanted you to, and why don't you tell the supervisors what your position is so they know who you are.
Oh, I'm the new Director of Finance for the General Fund Departments of HHS. So I'm over 5 departments, behavioral health services, public health, custody health, community health, and EMS.
Pleased to meet you. I'm
Thank
Joe
you.
Samiti, and I'm a county supervisor, so now we've been formally
Thank
introduced,
you.
okay?
So Supervisor Samiti, and I think what's important when you see WET and the CFTN is counties have the opportunity, if they choose to do this, to pull a percentage of money out of the CSS pot and use it in those two areas. And in our county, prior to my arrival and since I've been here, we are continuing to pull money out for workforce education and training, and we've also used some of that funding related to our EHR, the CFTN, related to our electronic health record implementation. So that's what those dollars are for, but they come out of the CSS pot.
Thank you. And as I said, I was just trying to figure out how if 100% went to 3 items, there was still money left over for 2 items. And now I know that the answer is we have some flexibility as to the first category. And by the way, we have some leftover money from back in the day. Yes? Okay. Now, before we let you move on, Ms. Tullies, I know you've shared this with the board before, but on the unspent balance, those numbers are substantial, and I'm guessing that we're going to talk a little bit about the plans for the future. But could you refresh our memories, or at least my memory, on how we ended up with the accumulation of funds over time? I know that was a source of controversy in some counties around the state. My recollection is that our sort of unspent fund totals were sort of about average or typical for counties of our size. But could you just revisit that issue briefly?
There's not a single reason. There are multiple reasons. We had unspent funding prior to my arrival where the department had launched RFPs, wanted to start up programs, but there are delays in that. So if you go through the procurement process, if you're standing up new programs and you think we've got this funding and we're going to get it out the door, there are many times, not just in our county, but in all the counties where it takes longer, so the funding accumulates. I think the other big piece on this is it's very difficult. We get these estimates from the state. This continues to this day, so that we try to plan our plans around the funding, but then we receive a big bolus of funding that's unexpected. And it's very difficult to try to get it all out the door the same year. the stakeholder process, the plan process. For us, I think it's a few things. I think hiring staff, both in the county and also the CBO's ability to hire clinicians. We're trying to address that. The other thing is just the startup. So we can put a lot of money into an RFP process. The RFP processes take a minimum of 6 months. Then you try to get those up and running, and often there's a time lag from awarding a contract to actually being able to implement the services. So it's a combination.
Thank you. Before I ask Ms. Cheong to go forward, do you want to insert questions or comments at this point, Supervisor?
I do. Thank
Thank
you
you.
very much. And thank you for that history and explanation. I'm curious to know, and let me know if this is going to be part of the report going forward, if there are particular major areas in which we are intending to spend down those
Yes.
unspent funds, because I see that we are eliminating that. And you mentioned in that list of things, CBO clinicians, and I'm wondering if the 12% increase that's gone to CBOs is being taken. Is that part of the way in which the funds are being spent down, and are there other ways that we might ensure that our community partners are really robustly funded and able to handle the work that we'd like to give them?
Well, we just released on Friday multi-million-dollar, many millions of dollars, the RFPs on the two biggest services in our adult system that we haven't had in this county before.
And what are those?
At the level one is called Assertive Community Treatment Team, and I know Supervisor Samiti and you specifically asked about this, and that's why I'm responding. It's a service that is evidence-based, has been implemented across the country, most effective evidence-based practice in our field. Santa Clara County didn't have this. It's for the highest level of need for individuals that are in and out of hospitals, homeless, custody, a whole panoply. So we're investing heavily. We've put into that 200 slots for adults and actually 120 slots for our forensic clients. So this means a very extensive staffing structure and a 24/7 approach for people with the goal of reducing homelessness, reducing hospital visits, reducing incarceration. Very effective. So that was released, and I want to say, I'll get back to you with the numbers, but they're very high. In addition, we have what's called a full service partnership in this county. It was procured right when I walked in the door. And we did a couple of things here that I think in the end were not the best way to go. It's what happened, so you move forward. But we didn't allow sufficient funding for individuals that really have high levels of need. And we scattered those services across the county. And in an evidence-based practice, to be effective, you usually serve between 50 and 100 people. So we've just redesigned, it's based on our MHSA assessment. We've redesigned and added what will be 400 or 500 slots for adults. We have slots for youth. Again, very high-level services that will be community-based. Where individuals can go and receive services. It could be 12 months, it could be 18 months, it could be 2 years. But providing what we're looking at is close to 1,000 new slots for clients and this very high level of care. I think that, first of all, you'll see a big drop in the MHSA unspent because these are expensive services. But I also think that we'll see individuals that are currently in involuntary settings and could be in the community, bring those out. People that have been in and out of custody are very likely to get a different kind of service and stay out. So it's been a big planning process, but those RFPs are going out. They're not being county operated. And I think the due date is the end of March.
And will we be investing more in custody health directly as well?
We're using MHSA for our jail diversion, some of our jail diversion. We have county general fund for that. But we do have a lot of other programs as we build out what we're calling diversion and justice services rather than criminal justice, which is stigmatizing. And so in those services, we're continuing to expand. And I expect either in this plan update or the next plan update, there'll be an ask. Most of those services are provided in the community, and we're seeing big upticks in that population. So yes.
Thank you.
Thank you, Ms. Young. Thank you for letting us interrupt and catch up a little bit.
Sure.
If you'd like to proceed, go right ahead.
So I wanted to mention that of the unspent balance when we close the books in FY18, that's the 129 million. That actually does not include the prudent reserves. We also have about 20.7 million in prudent reserves. And also part of the increase in the unspent balance is because the county, we received higher than expected funding from the state. We received about 9.1 million more than what we anticipated previously. The next slide is more details, a little bit more details on the funding and expense, and I'm going to turn it over to Virginia, who is a finance manager for behavioral health.
Hi, everyone. So this slide more visually summarizes the information that Tess had presented. You'll see the bar graph as well as the line graph. So if you look at the dark blue line, that is the state funding that we have received over the years with the expected funding for FY19 and FY20. And then the bar chart, this is the expense broken out by component. So you'll see that the green is CSS, the blue is PEI, the orange is innovation, the gray is wet, and the yellow is CFTN. So you can see by component how have we spent with the total in that table at the very bottom that says total expenditure. So in FY18, you'll see that we had received the $91 million and we spent down $84 million. Now, this year in FY19, this is the first year where we're really expected to exceed the funding with our spending. So we're going to spend more than what we receive from the state and continue to do so in FY20. We have a very aggressive plan from the 3-year plan.
Let me stop you there just and ask the question. If we can go back to that slide. So if someone said, and I see the bar graph obviously sitting in front of me, but if someone said, so we're now going to start to use up some of the surplus that we've accrued over time, what's new or more? Where's that money going? What's the focus of that increased spending? Is there a simple answer to that question?
Largely the older adult redesign, which is really where the service gaps are in the system. So all of the different programs that we put in that.
And when you say that that's where the service caps are, largely that's where the service caps are in the system, is that shorthand for, and that's why we want to use the MHSA money there to alleviate the problem that the caps create?
Yes, because the gaps are the individuals who are falling out of EPS, coming out of custody, homeless, mentally ill on the street, individuals that are frequent utilizers in any of those settings. And so the services that we're putting in place are evidence-based, and they are all designed to specifically address the needs of that population.
Thank you. Thank you very much. Keep going.
So our last slide is on the prudent reserve. I just wanted to give a quick history on the prudent reserve as well as where it's going. So in FY 2008, there was a one-time transfer of $8.2 million into the prudent reserve. And the prudent reserve is basically our rainy day fund. You can't touch it, but if in case of an economic downturn, then, this is money that we're able to access. In fiscal year 2010, an additional $11.2 million was transferred. And so sitting at this month, the balance including accumulated interest is $20.8 million. Now, the DHCS, they're in the process of issuing an information notice that talks about revising the calculation of the prudent reserve balance. And so the counties are waiting and seeing right now of what the final issuance will be.
Can I ask a question?
Please.
Is there a required floor or cap on the prudent reserve?
There's a cap. So right now it's 20% of the distributions.
And what percentage are we?
We're basically at the 20%.
Okay. Do you feel that it's important to keep it close to the cap? Would we still be in good financial shape if we took the cap down so that we could spend more on services? Not took
We
the cap
haven't-
down, sorry, took the amount of the reserve down.
I would try to maximize what we leave in the prudent reserve balance, just because in an economic downturn, it's not going to be done in 1 year. It's going to take a couple years. And so we just want to make sure we have sufficient fundings to continue to provide for our programs.
Spoken like an excellent finance manager. Thank you.
Thank you. Go right ahead.
That's it for the PowerPoint.
Right, the end. All right.
The end.
Thank you both very much.
You're welcome.
And Ms. Tullies, anything you want to add or that your team would like to add?
Well, I'm getting lots of texts from people, so I think in addition to the adults, I want to emphasize that we're dramatically expanding our transition age youth services. That's a population that we really want to make heavy investments there so that they are successful and don't wind up chronically mentally ill in our adult system. And of course, the other thing we've been able to do in the innovation funding is fund Headspace and other innovative projects. Those are short-term funding, but I think we're doing things that the community and the providers recommended, and so those are the areas. There are many, many areas. We're expanding peer workers and consumer family roles. All of that is funded. So it's a very broad array, but the biggest cost is the adult system.
Thank you. Let me just ask a few questions, if I may.
You may.
Then turn to Supervisor Ellenberg. But again, we're going to try and facilitate a slightly more conversational style. And so if you got something you want to chime in on, just lean forward and say, excuse me, Supervisor, or excuse me, Ms. Tullies, and see if we can share some information here. So let me go back to this issue of the unexpended MHSA funds. We have a 3-year plan, and I guess from the looks of it, it looks to me like that's going to work. That you feel like you have the ability to move the funds out in a responsible and productive way on the timeline that we previously discussed. I think it was last June when the full board took this up. Is that an accurate assessment of
Yes,
where we
it is.
are? Okay. Any other thoughts about that process, where that will leave us at the end of 3 years?
Well, I think I want to emphasize, especially for Supervisor Ellenberg, that we conducted a very thorough assessment of the MHSA funding and what the gaps and needs were, using data and also many, many, many focus groups and individual interviews. So the result of that work was what led to what we've got in our current plan. We spent about a year doing the assessment, and so we're into year 2 of a 3-year plan. We'll have 1 more year, but we'll be starting the next 3-year plan in 2020. So we'll see. I'm very optimistic that the plan that we've put in place will help not only to reduce the unspent funding, but really quite important to all of us, is provide people with services that we currently don't offer.
Yeah, I mean, at the risk of stating the obvious, the goal isn't spend the money. The goal is to improve people's circumstances by spending the money. So,
and one more thing I would offer is the design that we put in place and that we shared before of this committee is we're really looking at the number of people who are currently in hospitals, who are in the state hospital, who are in involuntary settings. All of those are expensive, and what we're trying to do is bring people into the community and reduce the number of people in those settings. So we could see a big cost savings from that. We're hopeful.
and am I remembering correctly that it was Darrell Steinberg who was the impetus behind the measure back in 2004, state senator, then now mayor of Sacramento?
Yes.
So we had a mental health program, obviously, before these funds were available to us. Could you sort of describe for us, this piece is related to this piece, how? Meaning, what was there previously, what we had come to understand a county's mental health responsibilities and funding responsibilities, what was that for, and how is that different from what we're able to do with these funds? What's the relationship between the MHSA funds and the work that's done with those funds, and, quote, the rest of the program, which I'm sure is even a little more complicated now that we're in the world of integrated behavioral health. But was that a clear question eventually?
I may have to ask you for clarification, but let me try to respond concisely. The Mental Health Services Act was designed, certainly Steinberg and many other people were at the table, very much as a means to try to provide an ongoing funding stream that would really focus on wellness and recovery for people with serious mental illness. That's what it was. A big focus of the MHSA was trying to get homeless mentally ill housed and in services. What you see the team provide to you today, those areas of funding were alive on day one, and they continue to this day, but there have been many regulatory tweaks and more expectations, I would say, particularly in prevention and early intervention. So in the first several years of MHSA, there were always stakeholder process, which were very important. With, I was doing this in another. Anyway, we did a lot of things that I think were really important. Big investment in consumer families across the state, workforce education and training. We're required to do full service partnerships. And there were a lot of innovative services that may have indeed helped individuals, but got a little bit outside the box, let's put it that way. So what we have today is, I would say, more rigor around the MHSA. We have a lot of reporting requirements. It's very clear how we can use the money and in what way. We still have wiggle room, certainly, but I think that there's much more of an administrative oversight than in the early days. I was involved in the MHSA from the inception, working at the state. So that's what I would tell you.
Let me try it one more way.
Okay,
Mr.
do it
Marcola.
another way. I'm not getting
No,
your
I
answer.
I got a lot,
Okay.
but
I can jump
Okay.
in.
Jeff, can you help?
But here's what I'm trying to get. So this happened 14 years ago.
Yes. Right.
How is the world a better place if it is by virtue of these funds? What are we able to do for people today that wasn't getting done 14 years ago? My recollection is back in the day, we were sort of limited to whatever Medi-Cal and some other funds would or wouldn't
Inpatient
fund.
primarily.
Right. Let me try to jump in.
Thanks.
Back in the day, the state had already made the decision to, as they say, carve out mental health, which basically turned mental health into the first type of HMO, a specialized HMO in each county. And it really focused almost exclusively on emergency services and inpatient services because it was stuck in this fee-for-service mode that you got mental health services if you showed up. If you didn't show up, you didn't get mental health services. The advent of MHSA was really designed by the legislature in order to expand the scope and expand prevention and provide more robust, comprehensive kind of mental health services. So the first rules were that you couldn't use this to supplement, supplant the current benefits. You could only use them to do these 5 categories that were just mentioned, which focused on prevention and comprehensive care and community care.
Correct.
And it was done by taxing the $1 million plus range. Since that time, we've improved because we've been able to provide more and more community services, which in this county we've done mostly through contracting with CBOs, some other services too. There's been lots of changes in regulations and changes in the fee-for-service structure, but those are a different subject for a different time. So it initially required quite a thorough review and approval by a separate stakeholders group. That requirement has been weakened a little bit, but not completely. And we've had quite a bit of success with community-based involvement and prevention and trying to catch problems before they turn into disasters. I will, since I have the mic, make one comment about the funding. Because this was funding that taxed the $1 million plus makers, it becomes a very unpredictable source of funding because there's lots of opportunities for those individuals to hide their money, avoid the payments. You know, obviously the number of people making $1 million a year changes depending on the economy. So I would also add one of the things that wasn't really said about the recent accumulation is that we did really well predicting how much revenue we were going to get until the last 2 to 3 years. And much of that had to do with the economy improving and the number of millionaires increasing and the fact that there were new revenues coming in that couldn't be projected. It caused a big part of the accumulation in addition to the issues that Tony mentioned. So we have to keep a prudent reserve for the potential of a downturn, which the legislature very appropriately built into the law because they knew they were tapping into a fairly inconsistent revenue stream. But we're going to spend as much as we can and spend down that reserve as much as we can, realizing that when the downturn in the economy happens, we will have a downturn in MHSA. Sorry.
No, thank you. Very helpful, all very responsive. And then connected to my interest on this one is there was passing reference to Proposition 2, which was on the ballot. My recollection is that Proposition 2 was the measure that said such funds can be used for housing purposes. Am I remembering this correctly?
Prop 63.
Was it
That's correct.
for the Prop 63 funds could be used for housing purposes?
Yes, it's also called a no place like home. Yeah.
And then I think my own view is that's an appropriate use for the funds, but you sounded, I thought, a cautionary note about the fact that that means if you're spending it on housing, it won't be available for other things. And so I guess if there's comment on that, I'd sort of like to know longer term. It sounds like in the short term we're cushioned because of the surplus that exists, but is this a source of concern longer term in terms of the use of the funds if some of the funds are going to housing, or do we just think sensible reallocation, nothing to worry about here, folks, take comfort?
The voters voted for that. You know, initially it was legislation, and I think people in California said this is really important. So the funding is actually coming from the state level MHSA pot, and it may reduce our funding, but that's what Tess was sharing. We don't know what that means yet.
So to be determined. Right?
To be determined, but the focus is on housing our people. So
then it wouldn't be moving along, it wouldn't be a conversation about this subject if I didn't ask you about Headspace. Thank you for the reference to the Headspace program. And for those who wonder why we're exchanging smiles, it's because this is a program that I had some early interest in and supported through an inventory item in the budget. And then at a much larger level, the county embraced the Headspace effort. But it just, like everything, it just takes too darn long. So could you give us an update on what the impediments are, and perhaps more importantly, what the hopes are about the ability to move that program effort forward?
is Cha here? Could I have Cha C, who's managing that project, make a couple of comments? I'd like my people to be able to comment to the board. Okay.
Good afternoon, supervisors and county executive. I'm Chaucy, one of the program managers with Behavioral Health Services. So for Headspace, as many of you know, it's a first-in-the-nation initiative that we're trying to build and replicate here in the nation with the help from Stanford Center for Youth Mental Health and Wellbeing. To date, we have achieved several milestones. We were able to develop the framework by which we would implement Headspace here in our county in Santa Clara. And a part of the framework is to provide an integrated care model that would be open to all young people regardless of their ability to pay or health insurance status. So we're looking at behavioral health services, which includes mental health, substance use treatment, employment support, educational support, and physical care. And so we have that framework in place with help from the Stanford Technical Assistance Team. We've been speaking to the Foundry model in Canada. We took a visit there last year in October. We also spoke to the experts from Australia, and the TA team from Stanford has been instrumental in connecting us with other experts in the field. In addition to that, we've been able to create a comprehensive evaluation plan to date in partnership with our consultant. So the next step is to really open up a site. And we've also developed the Youth Advisory Group. That's one of the innovative pieces of Headspace, is to have young people really inform the services and the environment and the design of Headspace. So when we talk about mental health and support, we really want to ensure that all the young people will be able to eliminate stigma. They will feel comfortable in accessing services. And we've been able to have the young people involved in designing the Headspace design plan and also the evaluation plan. So they've been a part of our monthly and biweekly evaluation plan. So we also have the.
Let me just interrupt for a minute here, because there's a key question, which is yes, and I think somebody is anticipating it here, which is you said the next step is to open up a site.
Yes.
Which I think means we haven't actually been able to deliver the program services yet.
So we have been able to identify one site in San Jose. We've partnered with our county fleets and facilities and Stanford TA team. So that's on 2nd and Key Street, the 2nd Street studio. So we're in the process of working with an architect to develop the plan. So for the North County site, there's been a couple barriers. Number one, we've originally focused on identifying county-owned facilities, and it's been very difficult to find county-owned facilities. And the second one is the budget issue for the tenant improvement. So I'll defer that item to Tony if you want to talk about the budget piece. But for the San Jose site, we were able to work with our real estate agent, and we identified the 2nd Street studio commercial space, and we're in the process of working on the architecture.
Yeah. And Ms. Tully, as I said earlier in the conversation, I want these to be candid conversations. So, I'm going to be candid, which is we've been talking about this for 4 years. A significant amount of money has been spent. There seems to be organizational-wide enthusiasm for doing this. I've not heard that anyone is other than, let's make it happen. But we still don't have sites. So what's it going to take to get us some sites so we can do this? And I mean, I understand the challenge, and I did have somebody from Facilities and Fleet actually tell me, gee, real estate's expensive in your district, supervisor, and I said yes, I was aware of that, and so what's the next step? How do we get past this hurdle so that we're not having the same conversation a year or 2 or 3 from now?
So I think there are important pieces to Headspace. We need a physical site that will attract young people. We want there to be transportation means. We've looked at numerous sites that are county operated, and then they started showing us leasing sites. And to be quite candid, it was really challenging. There wasn't enough space. It wasn't in the right neighborhood. I mean, it's boring. That's not what we need to share with you, but that's been the delay on the space. 2nd Street Studios is a new place. The county's doing supportive housing there, or affordable housing. It's a really good fit for us. We actually met with the architect on Friday, and in the partnership with Stanford, they actually brought a donor. We're trying to get some private funding as well, so it was very productive. And I think the next step is we met with them on Friday, and they're sending us information that we'll be going and looking in the North County as well to get something up. It hasn't been a lack of energy or lots of activity. There hasn't been the right spot.
Well, let me just ask Dr. Smith and Mr. Santiago if at our next meeting of the committee we can get a report back on what targeted measures we can take in the immediate future to get past this roadblock. and I'm not asking for that again with any implicit criticism. I'm just saying 4 years later, we still don't have a site. That's a long time to have come up short on what is the essential ingredient to providing the services. I know it's difficult. It's, certainly in my district, I understand the challenges, but if that's a necessary precondition to getting the services delivered, then, we can't just keep telling ourselves, gee, it's hard. Ms. Santiago, I see you leaning in. I don't want to call on you if you don't want to be called on.
No, we'll definitely follow up on.
Which I know you share about the lack of a site to in any way diminish my communicating the appreciation for the effort. I feel like we're on the cusp of something that could be remarkable. We hope that it will be. And so the frustration you hear in my voice is, let's go. Let's get there. Okay.
Supervisor,
Thank you.
before
Please.
we move on to a different topic, and Chauncey is still at the table, I'm going to ask some questions as
Please.
well. And I will focus on San Jose because it does sound like there is a site there, so we have overcome that hurdle. And so I'll ask several questions and then take them in any order you like. Now that we have identified a site in San Jose, what do you expect the time frame to be from today until the first teenagers walk in the door? I'm curious to know what process you're using to identify participants for the youth advisory group, which I think is a fantastic idea, and I really appreciate that you are engaging youth from the very beginning in the design. And then looking ahead optimistically to when this opens, what other, if you're already thinking programmatically, what kind of partnerships are you looking at with schooling services or with school districts? I know that Downtown College Prep is just a few blocks from the 2nd Street studio site. Those are all things that I'm curious about, and I hear your frustration. I don't blame you, but I want to thank you for getting this ball as slowly as it's moving, getting it rolling, because it is a desperately needed program. I saw this for years in our middle schools and high schools, and an increasing number of kids who were either receiving diagnoses or remaining undiagnosed with fairly significant mental and behavioral health challenges, eating disorders, substance abuse pieces, and the stigma is still there. So in my view as well, this cannot open a moment too soon.
Yeah, so I'll tackle the easiest question first.
Good plan.
So the technical assistance team at Stanford has been our contractor to identify and develop the youth advisory groups. So far, we have 2 groups, one in San Jose, one in North County area. And the process by which we identified the participants have been in partnership with the 13 SLS districts. So we've been working with each of our SLS coordinators, either at the district level or at the school site, to conduct outreach. We've had Stanford come and present to our SLS stakeholder meetings, and the youth coordinator at the Stanford team has also reached out to, I believe, over 50 community-based agencies in the county to reach out to foster youth, ethnic specific groups. So it's been a pretty robust process. And we've actually had some of the youth member attend the Oversight and Accountability Commission meeting in Sacramento to come and talk about the project. So that's been an exciting process.
I would also encourage you to present at some point to the youth task force that we have, or task force or youth commission at the county, just more good resources for spreading information. Thank you very much.
Yeah, so for the second question in terms of our partnership, one of the uniqueness about Headspace is also to create what we call a community consortium. So in other countries, they have an agency like a CBO who will engage other community providers and create a network of support. So the idea is for us to, we've actually identified a CBO through an RFP process to provide the service at the San Jose site. So once that process is completed, the CBO will be in charge of creating a community consortium. So they will go out and create a network of support so other agencies can be a part of this Headspace consortiums, and it would serve as a a group where we can link young people to if services are not available at the site, or some of these network providers can provide their services at the site, whether it's a workshop, drop-in services. So that's a piece of the model that we're replicating here in the county. And in terms of the time frame, we just met with the architect, and the goal is to open up and operate a site this year. I'm hoping we would get and this is also dependent upon the landlord, because he is the one hiring the architect. So once we get the contract with the landlord completed, then we'll go ahead and get the process for the construction going. So I would say our hope is early FY 2021.
2021?
Yes, because that's after.
2020.
I'm sorry, 2020. Yeah,
Oh.
yeah. So this fall.
Okay.
Yeah, sorry.
Keep asking, it's getting closer, so.
Thank you very much.
Good. Thank you again. I did want to move to the issue of the PERT teams and the mobile crisis teams, and get a refresher on here's what one does, here's what the other does, here's how they're different, here's how they're the same, but also just sort of how we doing.
We're doing pretty well. I think from a service standpoint, we're doing extraordinarily well. I think we need more clinicians. We know that. We're now going to reach out to licensed psychiatric technicians and psychiatric nurses who have a lot of experience with people in crisis, because we've had challenges trying to hire licensed clinicians. We don't need all of them to be licensed, but we do need on each team a licensed person, so we're going to try that. In terms of the work that we're doing at this point, we've served almost 500 clients in the last year. We've got 3 of the clinicians have gone through the hostage negotiation training. We have prevented some pretty significant situations, working very closely with law enforcement that could have been dangerous to individuals, and been able to get those people into services. Yesterday was, and I think we're very proud of this, we meet monthly with the county chiefs and sheriff, and we're talking about the work that we're doing, and I wish they could be here and share some of the things, but it's pretty extraordinary. We need more staff, and we have a plan for more staff. We are hiring individuals that may not have a lot of experience, but are enthusiastic and have the right rapport with people, and mentoring those folks. So I would say we're just going to continue to work. ESA has been very supportive of this, and we interview people about every 2 weeks for that.
The PERT teams, if I remember, involve in actually embedding our mental health folks with the police department.
Yes, they are.
And the departments we're working with are?
The Office of the Sheriff, the City of Palo Alto, San Jose Police Department, and Morgan Hill.
Okay. And are we at a point where we're thinking about other departments, or are we more focused on saying we need to get ourselves fully capable of working with the 4 that we're working with?
Yes.
All right. So that's
the latter.
And then the mobile crisis teams do what, and are different how, please?
The mobile crisis teams will receive a call from one of our law enforcement liaisons or one of the law enforcement officers in the field. They'll describe a situation where someone is called a 911 for an individual that is expressing or distributing, what word do I want to use, demonstrating mental health symptoms. I think what's interesting, of all the people that we have treated, a very small percentage have actually been admitted to custody. Some have gone into acute care. Others have been receiving care or sent to urgent care, and then they're going into teams of services. We've had some recidivism, and we're looking at the data about those individuals that just keep showing up. But it is, I'll be honest, we've
Excuse
been...
me, if we could ask your backup band
phone.
to turn itself off, that would be good, please. Thank you.
Folks.
Go right ahead.
So we want to expand that. The police love us. They just want more and more and more. And so in our meeting yesterday, we heard that one of the counties is now using licensed psychiatric technicians to help with mobile crisis, because all of us are dealing with the same issues. So we're going to open up to that population and hope we get more.
And let me just ask one last question on this, and then I'm going to turn to Supervisor Ellenberg, which is does the system work in a fashion where I would expect that mobile crisis teams would not be called upon in the 4 places where we have PERT teams because they've already got folks embedded? Or are there reasons why even in places where there are PERT teams, they're going to call our mobile crisis teams?
The intent would be that the PERT teams would be working with that particular law enforcement agency and most likely would not be calling mobile crisis.
And the mobile crisis teams then would predominantly be responding to the other 11 or 12 jurisdictions where we don't have PERT teams.
Yes.
Got it. Thank you. That's helpful to me. Supervisor, thank you for your patience.
One of the areas in which the mobile crisis team is called regularly is the area around VMC, which is in my district, and I know that I heard a good deal from neighbors in that community, and of course, before my time, they received promises that there would be a front-facing hotline for them to use. It sounds like it's working really well from the law enforcement back channel, but what can I take back to my community to tell them how soon they might be able to directly reach out as well to a single number that can then farm out the right authorities or support?
That's coming soon, so can I get back to you and Supervisor Samiti? And we're actually working on that and trying to figure out how to make that work.
Wonderful.
With insufficient staff. I think the other thing to tell you about the VMC area, we'll be standing up a county outreach team that will be focused specifically on people that are coming out of emergency psych who have not been hospitalized but clearly have needs. And so one of the things in the MHSA plan we are doing an RFP on this across the county, all across, but the county team will be central in the area with the highest 5150s, and they will know who's coming out of EPS and be doing a lot of outreach to try to get them into services.
Great, and I understand there is supposed to be a discharge plan when people leave the hospital rather than to just be exited onto the street without a plan. Is that correct?
I think Paul might want to respond to that.
Thank you, Tom. Supervisor Ellenberg. So every patient that is discharged from the hospital are required to have a discharge plan, which ensures that the individual's clinical needs will be met upon discharge, and we do our best to ensure that their social issues and challenges are also addressed upon discharge.
But you can't compel them to follow those plans, of course.
We
And
cannot compel
you can have
them
a terrific plan and someone can still walk out the door and say, no, I'm good, thanks.
That is accurate, but I have to also share with you, Supervisor, that our staff, the social workers in particular, go to extraordinary lengths to ensure that their well-being is kept in mind.
I appreciate that, and I certainly didn't mean to suggest that anyone wasn't caring, only that the adults have, free will to make their own decisions as they are leaving, and when they end up wandering around the Burbank community neighborhood, it becomes a neighborhood social issue as well.
Absolutely. Understood.
Before we leave this topic, Ms. Tully's, you were kind enough to say you would get back to Ms. Ellenberg and to me on the request she made. Would you like to do that in an off-agenda report, which is, by the way, a public document, or at our next meeting, either or both? Or how would you, I just want to make sure we followed through with you on that piece.
Why don't I do an off agenda? It's public. It's just easier.
Good.
Right, thank you.
All right, thank you. We'll look for that. We'll look for that then. Thank
And
you.
I think there's a prompt from your staff person. We're trying to hire 8 clinicians for the PERT teams, and we have 3 in the pipeline, but we've not been able to hire for those.
Because?
I think because we were talking about hiring yesterday. Often we get somebody all the way down the road. They're very enthusiastic. This has happened repeatedly. And then in the end, they decide to stay in the current job. And largely, it's been because of evenings and weekends, to be quite candid.
Yeah, no, I know you've shared that with us in the past.
And so the reason that we want to look at licensed psych techs and nurses is they work in 24/7 facilities. And we think that there's a higher likelihood, we've had a conversation yesterday, that they're more likely to engage in an evening or a night shift. So,
thank you. before we leave this item, we do have a card from a member of the public who's been very patient, or at least I hope she has. Lorraine Zeller, you want to come forward and share your comments with us at this time? Thank you.
Right here?
There is a microphone embedded in the podium right there. It is invisible, but if you speak right at us in a good, clear voice, we will hear you.
Thank you. Good afternoon. First of all, I'd like to thank you, Supervisor Ellenberg, for coming to our peer respite on grand opening. It was great to see you. So my name is Lorraine Zeller. I'm actually speaking as a follow-up to a statement that I made at our Behavioral Health Board meeting on the 14th of January. I am a mental health peer support worker, very, very happily. I love what I do, and it's paid through MHSA funds. I'm here speaking as an Access ambassador. And Access, it stands for, it's under NorCal Mental Health America. It stands for Advancing Client and Community Empowerment Through Sustainable Solutions. The mission is to strengthen and expand client and consumer stakeholder advocacy in our public mental health system. And I've seen the process in our system, and, you know, with all due respect, I'm here to offer some recommendations for improvement. At the stakeholder meeting on December 10th, I noticed that there were some changes that in the older adult programs that were not decided or discussed by participants at the stakeholder meetings in October or November. Under the MHSA general standards, client-driven programs and services use client input as the main factor for planning, policies, procedures, service delivery evaluation, and the definition and determination of outcomes. Without meaningful input, consumers and other stakeholders feel increasingly marginalized and without a voice regarding important decisions about the public mental health services and policies and services that directly affect us. I'm asking for your support, and before I say this, I do want to say that our MHSA coordinator, Evelyn Termalai, graciously accepted my request to meet with her to discuss this. I'm asking for your support for the behavioral health services to institute changes in their MHSA planning process that will result in increased client stakeholder participation and increased transparency regarding the MHSA planning and programs. So I will be submitting to you recommendations. Okay. So I'm submitting my comments and recommendations and supporting documentation.
Thank you. And as you can see, the clerk's going to take your comments. We're going to ask the clerk to reproduce them, share them with members of the committee, going to pass them along to you, Ms. Tullies, I believe, and then let you get back both to the community member and to us with your reaction, if you would, please. And I see that Ms. Ellenberg has some thoughts on the subject as well.
Thank you, Ms. Zeller, for sharing your comments, and I certainly appreciate your couching them in terms of what we can do better and improve as opposed to what's wrong. And I just want to add my support to your suggestions, which I think are excellent. I'm not sure you made it through all of them during your 3 minutes. That time goes really quickly. But I think that the interest in expanding the size of the stakeholder group, making sure that community members really feel invested, perhaps looking at other county models that meet more regularly, would be good ways to expand and increase the buy-in into what is a very, very important process. So if you haven't seen her letter, already. I know that Frank will get it to all of us, but I will look forward to hearing your thoughts on it as well.
Thank you very much. All right, I think that completes item number 5. Thank you again, Ms. Tullies. Thank you to your team. Thank you folks who are here. And it takes us to item number 6, which is to receive monthly reports. And as I mentioned at the outset, this is one of the places where I'm hoping that our process permits us to make the agenda a little different at this meeting and at subsequent meetings. What I'm trying to highlight is that I'm hoping that this section will be one where we're asking people really to give just verbal reports on the one hand, now you know it's me, to dispense with the sort of longer written reports that I think have become a little bit burdensome on staff and staff time, frankly. But on the other hand, to provide us with something that looks like a monthly dashboard for each of the relevant reporters, so that we've got a sort of a quick way to access what's happening, what the developing trends are, without the necessity of a longer written report, still taking the oral report here and giving us the opportunity to probe in greater depth if we choose to, but really with the expectation that more often than not what we're going to do is say, all right, we're going to make time as we did today for a more extended conversation like the one we had with Ms. Tullies and her department. So everybody will get their moment in the sun. I know that's how you look at these experiences. Everybody will get their moment in the sun, but on a monthly basis, trying to make it both, frankly, easier to access for the committee and less burdensome for the staff. You know, today, for example, you know, we're going to get a report from the Healthcare Reform Stakeholder Implementation Work Group. What a great title that is, at some point. But, you know, in subsequent meetings, rather than have Mr. Brownstein come and sit here at every meeting, what I'm hoping is that we'll, again, get that sort of a dashboard look, maybe ask him to be here twice a year to give us a more formal report, or at some point actually do the deep dive that we did today. And the one other change I should surface at this point, Dr. Smith, is that I do think we need to have a monthly report from VMC on the hospital integration issue as a regular standing item, since that's going to be at the top of our to-do list for a while. So that's sort of how I see item 6 evolving over time. With that long introduction about what I'm hoping we're going to do here, I'm going to go ahead and ask that we just work our way through those reports as indicated on our published agenda. So let's begin. Before we go to the director's report regarding emerging issues, let me ask the county executive, as I indicated earlier, if he and or anyone from county counsel's office would like to tell us, as of 3/13, what's the status of our effort to acquire the 2 hospitals and the opposition we've received from the Attorney General.
Thank you, Mr. Chair. There was a hearing in Los Angeles Bankruptcy Court this morning at 10 o'clock, at which time the judge adopted with some minimal changes in formatting the tentative order which he had published yesterday. That tentative order basically says that the Attorney General has no authority to block this sale or to request a stay, and has shown no evidence that a stay would improve the quality of care or presence of care in the community. Therefore, the sale order, which was previously approved by the bankruptcy court, continues to be valid, free, and clear. That allows us to proceed with the close of the sale, just like you would with the close of escrow. The anticipated time for close is the 1st of March. That might bounce around a couple of days just based on mechanics, but we're proceeding full steam ahead. Really happy and proud of the entire county team, everybody here in HHC, plus all of county council and Miguel and a number of others who worked vigorously to make sure that we could make it through this entire complicated and very work-intensive process. The Attorney General still could continue to try to oppose the sale at the district court level. We hope that he does not. He put out a press release today criticizing the bankruptcy court, but did not indicate an intention to move ahead in the district court. However, one never knows what will happen there. And for elucidation of that process, I'll turn it over to County Counsel.
Mr. Coelho?
Sorry, Rob Coelho, Assistant County Counsel. I actually don't have anything to add to what Dr. Smith said other than to supplement the praise for the hard work of the folks up here from our office, the county exec's office, in terms of culling together very quickly, given a very rigorous time frame, the opposition papers with respect to the Attorney General's request for a stay, and to indicate that our office will continue working with county administration and our Employee Services Agency and all the HHS folks to try to make sure that we're doing what needs to be done to close on the date and on schedule, with the assumption that either the Attorney General won't take any further action, or if he does and seeks something in the district court, then we'll work very steadily and firmly with administration to oppose that request for a stay as well, with the goal of closing on time and making sure the sale occurs.
Thank you. I would just add, I think as I've talked with members of the public, there's been a certain confusion and frustration about what's going on here. We've got the one level of government suing another level of government, which is never a happy occasion, and folks are a little bit hard pressed to understand what this has been about. And occasionally people have either implied or said explicitly, is this some version of, do you people know what the hell you're doing? I'll just put it that way. And I wanted to read just 2 sentences from the preliminary opinion that was issued yesterday, and this is from Judge Ernest Robles. And I share these not to poke back at the state or the Attorney General, but just to give some assurance to the folks we represent here at the county. And again, I'm quoting directly from the preliminary opinion yesterday. Quote, "Far from protecting public health and welfare, a stay would set in motion a series of events that in all probability would reduce the availability of healthcare services to the public." That's the judge's opinion. And the other point, again, quoting directly, "Of particular significance is the Attorney General's inability to identify any specific provision of California law that provides him with either authority to review the sale or authority to insist that the conditions continue to apply subsequent to the sale." That's pretty straightforward, and is where you started, Dr. Smith, and I just thought reading the language verbatim might be helpful to people who are wondering, why is this a thing? Ms. Ellenberg?
What is the timing on the AG's right to file in district court? Does he have a certain number of days?
He does. I don't have the exact time frame, but my belief is it has to be within, I would suspect, 10 days would be my estimate. Mr. Marquez may have a sense of it, but that's my...
We did look at the rules, and the rules do note 10 days for the initial filing with the U.S. Bankruptcy Court. The next step is with the district court, so presumably it'd be the same 10-day timeline.
Okay, so this is not going to hang over us indefinitely.
And I should also point out that as long as a stay is not granted before the end of February, we still can complete the sale independent of anything that happens after that in terms of an appeal or whatever, because the close is final and cannot be appealed after it's done.
Thank you very much. All right, so 6A, receive director's report relating to emerging issues regarding the County of Santa Clara Health Service.
Yes, and thank you, Mr. Chair Simidian and Vice Chair Ellenberg. Appreciate. Good afternoon, by the way. That's a first for us here in HHC, and we'll get into a new rhythm. Hopefully also the operational reports, we compile them as we customarily do them, so it may take us a couple cycles, and we certainly welcome your feedback, whether we're capturing the meaningful information and data that you need, of course, to be informed of how we're doing across the variety of different operations as our health and hospital system. A couple things to highlight in my report. One of the things is obviously we're very pleased with the governor's both policy as well as budget proposals. We have an extensive update as part of the written report, and obviously we're very pleased that he's advancing not only the individual mandate and the expansion of services and universal screening, particularly for kids in our community, but putting money behind those initiatives. So we'll keep you informed as that goes through the legislative process. One note of concern is the 340B program, so we're going to keep tabs on that. Even though they did indicate it doesn't negatively impact public hospitals, but as part of our participation in 340B, we cannot participate in a larger pool, purchasing pool, so that's, we're going to have to watch for that in terms of how they implement it. I do see some of our community clinic partners and CEOs in the audience, and I give an update as part of the T2020, Transformation 2020. This is the initiative to transform our systems towards outcomes and value-based, includes our partners. Even though the highlight in this report is only focused on the whole person care, I know they're very interested about PCAP and the efforts to help along the care delivery reform as well, right alongside with our partners. And they've identified certain areas that we established a work group that we're working with in terms of streamlining the eligibility process, improving the communication, and hopefully successfully enrolling more people and serving more folks as part of our reform. So thank you for being here. And again, we'll work with our stakeholders and obviously the other partners that do regular reports to the Health and Hospital Committee as we change to this new format. If there's anything that we need to do, just let us know.
Thank you. Forgive me if I missed it while I was delivering a document to Dr. Smith, but I've mentioned before a concern about the downward trend on Medi-Cal managed care.
Yes.
How are we feeling about that? It looks to me like the numbers are still headed in what I think of as the wrong direction. Are we? You know, to be a little bit more upbeat, I can talk about the fact that we've got a pretty sustainable number, it seems to me, in the VHP covered California plans. But Medi-Cal managed care concerns?
Yes. Absolutely. This is something that we're watching very carefully. And as just for the Supervisor Ellenberg's benefit, generally, Medi-Cal is counter-cyclical. You have, obviously, less enrollees when the economy is doing well, except because we had national health reform, a major expansion. We had a surge, obviously, in enrollment. Now it's kind of dropping and leveled off. We tend to be doing well on the care delivery in terms of retaining the enrollees, but the number of enrollees in the managed care plans continues to steadily drop. And some of it is concerns related, at least what we hear anecdotally, is related to the fear of immigration and the threats from the federal government. So we're trying to communicate that and work with our partners to make sure that our clients are actually well informed about some of the potential risk associated with it. But more, I think the other big factor is we have a livable wage and we have a high cost community. So those are putting pressures, obviously, in terms of populations moving out and then potentially not qualifying for some of these programs that are based on income thresholds. So this is, again, Bruce might have a little bit more insight, but it is something that we continuously monitor and give you the data in terms of the trends.
Certainly. I could offer some updates that I was actually going to discuss in the VHP report, but it's timely now. If you look back to October, we were at about 120. We were at exactly 122,004 Medi-Cal members. Then we actually had the first uptick we've ever seen in quite some time in November by about 5%. Unfortunately, some more recent numbers that I was able to access that aren't in this month's report, that went away in December. It went back down even a little bit below October, but then there was a slight uptick again in January. So net of all of that, January is 122,015. So, a few more members than there were in October. Does this mean we've kind of reached the floor that we intuitively felt must be out there that we would hit at some point? It's a little too early to tell, but there is some indication of a stabilization.
Okay. Supervisor Ellenberg, anything else on this one?
Not specifically on that issue, but to your report, you mentioned the PCAP and the community partners. And I know that we have some tension right now with the community-based organization providers around contracts. The issues, as I understand, are not related to performance goals, but goals related to signing people up for PCAP, and the organizations are letting us know early on that the goals seem to be unattainable. I'd like to know how we are working with our partners right now to hear from them directly what their concerns are about the goals, what flexibility we have, and how we are planning to move forward sooner rather than closer to budget time.
Sure. And of course, we're dependent on the billing data and the flow in terms of information, and that's one of the barriers that our clinic partners have identified for us to work on, so that we have much more timely information and address some of the communication gaps that they need very quickly, and then obviously let us know as well in terms of some of the barriers. So what we've done is established that work group that's going a little bit more in depth in terms of the issues, what exactly is actually the gap, so that we can quickly address those. Different clinics are operating in different places. At least 2 of them have gone out of the gate pretty strongly, and they're actually, quite frankly, pretty much on target. So we're trying to identify what other issues are going on with the rest of them. And then, of course, to a degree, they're identifying system issues, like I mentioned, in terms of the streamlining the eligibility process, and then getting to some feedback very quickly on them in terms of the specific clients and what we need to do collaboratively. We're trying to do that as well.
My understanding is that the ones that you mentioned that are on target with the whole person care enrollment goals, as opposed to the PCAP enrollment goals.
Well, it varies. Some of them are in target because we have 3 programs operating. There's a PCAP, there's a whole person care, as you mentioned, then we have the global payment program, which is they get reimbursed on points. So it varies across the 3 programs. But what we could do is maybe at the next Health and Hospital Committee, give you a more detailed report for each of the individual clinics, and then, of course, the issues they're identifying, and then what are our action plans to resolve those issues.
If that works for the chair, I would appreciate that. If not, an off-agenda report would work as well.
That's fine.
That works?
Okay.
Okay, great.
Sounds good.
Thank
We'll
you
go
very
ahead and
much.
do that.
Thank you. And I should just mention, because folks are perhaps wondering, I do have 3 cards on item number 6. Ordinarily, we take all of the number 6 speakers at the beginning of number 6, but since the 3 cards are all for 6E, I thought it would actually have a more coherent conversation if we just wait till we get to that part of the agenda. So bear with us. When we get to that part of the agenda, we'll take all of the 6E folks. That does take us to 6B, working partnerships. Mr. Brownstein, you want to come forward? And I was saying earlier, when I think you were multitasking, that my hope is that what we'll do is ask you to come in future, maybe a couple of times a year, so you're not down here every month unnecessarily, but that we'll hear from you in between times, and then at some point during the year actually do kind of a deep dive to get a better sense of what you all are working on that's important to us and that we should know about in more depth. So welcome and thank you.
And Supervisor I'd like to briefly comment on 3 activities that the stakeholders are engaged in. First, a written report is being prepared on the issue of the health impacts that result from the federal government's very aggressive policies towards immigrants. This is based to a large extent on the event that was held last October. This report is being drafted with participation from a number of stakeholders, the Community Health Partnerships, Uplift Family Services, Gardner Clinic, the Behavioral Health Contractors Association, ACI, and my own organization, Working Partnerships, and we hope to have the full report available in about a month. Secondly, after the November election and the Democrats taking power in the House, stakeholders thought it would be useful to meet with Congresswoman Lofgren to discuss potential or possible legislation beneficial to the delivery of health services and the maintenance of health outcomes in the area. Topics that we thought we might discuss are diabetes prevention, medically tailored meals, funding for community health centers, and workforce development in the health field. Unfortunately, the first meeting that we had scheduled had to be deferred because the federal government was not in business and Congress could not leave Washington, D.C. However, the federal government is at least temporarily back in business. Our meeting has been rescheduled and will occur this Friday. Third, for years, many stakeholders have been highly concerned about the fate of the former Daughters of Charity Hospitals, O'Connor and St. Louise. Supervisor Simitian, you're probably aware that stakeholders urged the Attorney General to impose strong conditions on Prime, a deal that collapsed, and on Blue Mountain and Veritas, the deal that did take place and is now resulting in bankruptcy. These stakeholders are fully supportive of the county purchasing the hospitals. Supervisor Simitian, you mentioned there are some people who don't really understand what this is about. I assure you the people who've been working on this issue for years are fully aware of what it's about. If there's anything we don't understand, it's why the Attorney General is behaving in the way that he does. A very strongly worded letter has been sent to the Attorney General by a dozen stakeholders. The Santa Clara Family Health Plan has submitted a letter. San Jose Council member Davis, in whose district O'Connor is located, has submitted a letter, and networks are being mobilized to send individual comments to the Attorney General. Hopefully, this will all work out, and if it does, we hope to hold a broader meeting between the county and stakeholders to talk about the many opportunities that would exist to improve health care once the county takes over management of these 2 hospitals. Thank you.
Thank you very much for your report. Let's go then to 6C, the verbal report relating to federal health policy and the budget landscape. And are we looking to you, Mr. McGarland?
Good afternoon, Mr. Chairman. As we all know, the dynamics in D.C. have undergone a profound change since the Democrats retook control of the House and Congresswoman Pelosi returned as Speaker. The shutdown drama has been the main focus of everyone's attention the last several weeks. It is worth noting there's been a specific shutdown effect on the budget process in Washington that we're all tracking and following. Normally, the president's budget is released the first Monday in February. It's going to be delayed because of the shutdown for a period of time, and congressional action may be pushed back by several weeks. It's also worth noting that the House Democrats plan to try their best to move the labor HHS appropriations bill as early in the process as possible. This bill, referred to commonly as the Labor H bill, actually moved very early last year and was one of the appropriations bills signed into law prior to the shutdown, and as a consequence, our mainline health programs and funding were not impacted by the shutdown, as horrendous as it was for the other programs that were impacted. So it's prudent policy to try to move that bill early, get it out of the way, and have it out of the area of risk should there be another confrontation over shutdown later this year. Most media focus in Washington right now is still on the Pelosi-Trump dynamic and the various investigations that Democrats are teeing up to dealing with the Trump administration. There is in all of this, though, an emerging health agenda, and we have evidence for this agenda by the hearings that have been scheduled and conducted and bills that have been introduced. So we have something of a profile of what that health agenda is going to be. The top line issue, the one that there seems to be, remarkably enough, bipartisan interest in the House, the Senate, and the White House is prescription drug pricing. That's the one issue that seems to cut through the clutter and at the top of everyone's list. There were actually yesterday dueling hearings. House Oversight Committee had a set of hearings, or a hearing on prescription drug pricing at the exact same time the Senate Finance Committee tackled that issue. The approaches are somewhat different. Senator Grassley, the chair of Senate Finance, is interested more in transparency, in listing the prices of drugs as widely as possible, exposing through transparency the out of control dynamics of drug pricing in the hopes that the marketplace will correct the problem. And the House Democrats are focused on regulation. And the primary mechanism they want to advance is to have the Medicare program negotiate for all Medicare prescription drugs in a single unified action and use their market power, the federal government's market power, to drive down prices. So that's one dynamic, prescription drug pricing. There's also going to be this year a series of what are called, or what are referred to often as must-pass funding bills in health. And this happens every year or two. There's typically a package of bills that are going to expire, and if they aren't passed, they're going to stop operation, and they have bipartisan support. The package that we're dealing with this year includes funding for community health centers, funding for the National Health Service Corps, and a delay in the DISH cuts that were part of the Affordable Care Act. These programs, and there are a couple others that are added in as well, were actually part of a package 2 years ago that became a must-pass package, and they all got enacted 2 years ago in one single bipartisan action, and that 2-year window expires September 30th of this year, and there'll be a fair amount of activity around ensuring that those must-pass bills, in fact, are passed again. There's also a very aggressive oversight agenda that's developing in the Congress, and actually earlier this week, in fact, it was yesterday, the House Ways and Means Committee had a oversight hearing on the issue of pre-existing condition protections. That was one of the major themes of the 2018 election. How do we protect pre-existing conditions? Inspired, as you know, Mr. Chairman, from our prior discussions, in large part by this litigation in Texas versus the United States, where 18 attorney generals sued the federal government, essentially saying the Affordable Care Act pre-existing condition protection should be thrown out because the penalty for the individual mandate had been abolished through tax reform. And without that penalty in place, that taxing authority in place, the rest of this statutory scheme should be struck down. The federal district judge agreed with them and went beyond what most people thought and actually struck down the entire ACA. And as a consequence, this became a big issue in the campaigns last year, and members of Congress are very focused on making sure that pre-existing conditions are not undermined. So there was a hearing on that issue. House Democrats also plan a series of hearings in the weeks and months to come dealing with a long list of administrative actions that were taken by the Trump administration over the last 2 years to undermine the ACA through regulation, through funding decisions, and a range of other strategies. This includes the elimination of the individual mandate penalty, but it also includes things like massively reducing the funding for marketing and facilitating enrollment in the state exchanges, the so-called Navigator program, where people are hired to help people navigate through this complex system. It was funded at $63 million 2 years ago, then cut to $36 million, and now it's down to a budget of $10 million nationally. And that's had an impact. There also have been a series of waivers that have created a work requirement under Medicaid that has had the effect in certain states of reducing enrollment in the Medicaid program. There also have been rules promulgated that create these short-term insurance policies and association insurance policies. They seem like good ideas, except their primary purpose is to allow people to buy less expensive health insurance that avoids the protections of the Affordable Care Act. They don't have the essential benefits included within them, and they also don't have the pre-existing condition protections included within them. If you're young and healthy, this is very attractive. They're cheaper policies. Lots of people are being driven towards those policies, but the consequence for the rest of the system is higher cost. Under House Republican leadership, these administrative actions were largely unreviewed. House Democrats plan now to take a very aggressive look at what damage has been done to the ACA and look at the case and trying to build the case for restoring policies that have gone in the wrong direction. So the ACA is still alive. It survived major court challenge years ago. It survived the repeal effort in the House and Senate the last 2 years. It is surviving these administrative actions and rules that are designed to weaken it, but it is not surviving unscathed. There has been damage done to the program. There was a Gallup poll survey released last week that said that in 2016, there were the number of uninsured adults in the country was at 10.9%. In 2018, the end of 2018, it's at 13.7%. It's gone up 2 percentage points. The number of uninsured adults represents a loss of coverage for 7 million adults nationally. Healthcare.gov, the exchange run by the federal government in 34 states, has shown a decrease in enrollment of about 4%. Again, it's not destroyed. It isn't collapsing, as the president sometimes suggests, but it is being somewhat weakened. It actually is a significant reduction. In California, we have our own exchange that operates independently, Covered California. It's got a much more aggressive independent marketing program. It's got its own negotiation strategy. It only dipped 2% last year, which was relatively modest, less than the national average. And just today, earlier today, about 2 hours ago, they came out with the numbers for the open enrollment period this year, and it's bad news, but not totally bad news and not catastrophic news. They show that the big top-line number you'll read about later today or here tomorrow is that in new enrollments, Covered California dropped 24%. That's the number. Sounds like it is a big number, new enrollments. But because existing enrollees renewed their coverage in stronger numbers, larger numbers, it was like a 7 or 8% increase in renewals for existing members, the overall loss in coverage was about 0.5%. Nationally, we had this a 4% drop nationally in exchanges. California kept our loss to 0.5%. Again, it's not good news. We want to see it grow, not go backwards. But it's not as bad as it could have been, in large part because we have our own exchange and our own program. I want to touch briefly on something that Renee mentioned earlier, and that is the governor's initiatives in this realm. We have always been a national model for ACA implementation. Starting from the beginning in 2010, California has been ahead of every other state in how aggressively and how thoroughly it's tried to implement the ACA. Governor Newsom has actually put forward, in many respects, the most ambitious package in the nation to shore up and strengthen the ACA in the context of these Trump initiatives to weaken the ACA. And there are a number of elements in that package, but the one that is first in the nation, and maybe in my view the most significant in terms of ACA stability, is his program to create premium subsidies for people above 400% of poverty. When we've seen these press conferences over the last several years of families and individuals saying the ACA is a failure, we've had 10, 15, 20% premium increases, our family can't afford health insurance anymore, this program doesn't work. Those people are almost always in the population just above 400% of poverty. They didn't have the subsidies available. The premium increases weren't protected from them. They weren't making that much more money, yet they had to bear the full brunt of those premium increases. A logical fix for the ACA from the beginning has been, as these horror stories were shared with the nation, would be to expand the subsidies above 400% of poverty. And to his credit, Governor Newsom and his team have taken that issue on. No other state in the country has done that yet. This is a very important initiative, and again, will make California even more a national model for ACA implementation if he's successful. I want to make a brief comment also about the change in our congressional delegation and their roles and responsibilities. Obviously, California, in many respects, is the most influential state in the country in terms of the House of Representatives. We have both leaders in Speaker Pelosi and Minority Leader McCarthy from our state, gives us substantial influence. But it's important to note that we also have Santa Clara County delegation members who are going to play very significant roles in healthcare in the next 2 years. First of all, we have Congresswoman Eshoo, who is now officially the chair of the Energy and Commerce Committee Subcommittee on Health. This is the panel with responsibility for the Medicaid program and for much of the national healthcare agenda. It's the panel that Congressman Henry Waxman chaired for a very long period of time. It's where Medicaid policy gets formulated, and she's going to be in a very influential role as a new chair of that committee. And we've also seen in the last few weeks Congressman Khanna emerge as a House leader on the single-payer issue. He's one of the main authors of the House single-payer legislation, and he's also the author of a new bill that he's, I think, still drafting, but will soon introduce, that's designed to complement what Governor Newsom is doing on single-payer by creating a new federal waiver that would make it possible for the federal government to allow a state like California, should it seek to become a single-payer state, to consolidate all the federal dollars into a single-payer system. So we have two leaders, major leaders on healthcare in our region. I'd like to close, Mr. Chair, by going back to questions that you asked me at the November meeting, and you said when next we meet, you'd want me to come back and respond to those questions. So I've prepared a response to your questions. The first question is you wanted to understand better the arguments that were successfully used in the red states in this last election when voters in those red states passed by initiative expansions of the Medicaid program. They took up the ACA Medicaid expansion. Their legislatures said no. In some cases, their governors said no, but the voters in very, very red states said, we're going to do it. We're going to expand Medicaid. So what happened? How did that come to pass? So I've done the research, and here's my brief report on this issue. There are 4 red states that took up the issue of Medicaid expansion on the ballot: Idaho, Nebraska, Utah, Montana. 3 of the 4 measures passed. Montana failed, and I'll talk about why in a minute. But in Idaho, Nebraska, and Utah, about as red as you can get in terms of presidential election politics, they said yes, we want to expand Medicaid. We want to support the ACA. This is an amazing turnabout, given the fact that between 2010 and 2016, if you mentioned the ACA in those states, it was political poison. That all changed. Let's start with Idaho. Idaho had Proposition 2. It received 62% of the vote. They expanded Medicaid to 62,000 new Idahoans, no new taxes involved, largest margin of any red state. This margin was influenced in the last moment by the Republican lame duck governor, Governor Otter, endorsing the campaign and doing a television ad in which he said, we need to expand Medicaid. The pro-campaign that he was part of in the end referred to what was called a coverage gap, and this was a common argument used in all these states. What they basically tried to argue here is, listen, we have the Medicaid program and we have the health insurance exchange for higher income people. Between existing Medicaid and the health insurance exchange, there's this group between 100% and 138% of poverty that doesn't have access to health insurance. They're a gap population. They're unquestionably low income. They need health insurance, but they're in this gap population, and that argument resonated with people. You know, we've got to close that gap. Those people deserve to have health insurance. Governor Otter, in his ad, called this population very hardworking. They also used the theme that we're leaving federal money on the table. You know, we're paying federal taxes. Other states are expanding. Most states have expanded. Why should our state leave $200, $300, $400 million in federal money on the table and not claim that money? And that argument worked as well. Now, what was the opposition argument? The opposition argument was remarkably similar to what House Republicans argued in all of their hearings in 2017 and 2018 when they wanted to repeal the ACA and they wanted to reverse the Medicaid expansion. They argued that Medicaid is a program for primarily and originally for pregnant women, children, and the disabled. Why should we allow able-bodied adults, and that's the buzzword, able-bodied adults, to be in this program. And if they're in the program, what they argued is they're going to siphon money away from children and the disabled. They argue as if it's a zero-sum game. You put able-bodied adults in, and by implication, able-bodied suggests they're not doing what they should be doing to earn a living. They shouldn't be in this program. They don't deserve to be there. And that's the argument they made. And it failed by a large margin. Now, Nebraska, just briefly, it passed in Nebraska with 53% of the vote, covered 87,000 new enrollees. Arguments were somewhat similar to Idaho. One of the other factors I have to point out is, surprisingly, the yes side in all of these campaigns outspent the no side substantially. You might have thought otherwise, but in fact, out-of-state money from various organizations, and one of the key organizations appears to be the Fairness Project, which is a California-based group committed to economic justice. They have a lot of labor funding. They've previously worked on minimum wage expansion issues, minimum wage guarantee issues. They shifted their focus a year ago to Medicaid expansion, and they put a lot of money into these states, $1.7 million into Nebraska, and a similar or larger amount in the other states. They were the single biggest funder. So you had the yes side outfunding the no side because there just wasn't an economic engine or set of stakeholders who wanted to invest money in a no argument. There was, just to show you how clear this no argument about these people don't deserve Medicaid was in Nebraska. Nebraska newspapers described, and I'll read their description, an ad that was one of the main no ads. And basically they said this ad said we shouldn't be giving free health care to able-bodied adults. And it showed a young, healthy-looking, bearded man slouched on a couch eating potato chips with the crumbs spilling onto his chest. And that was the image they tried to portray, implying these people, in fact, are undeserving. The yes side countered with these are hardworking people, low income, they have difficult jobs, they deserve health care. And again, voters didn't buy it. It worked in Washington in those congressional hearings, but when you put it in front of voters in a real state, in a real environment where the issues were before people, it didn't work. And then Utah, to conclude, they actually had a small tax increase attached, small sales tax increase, 4.7 to 4.85, very tiny sales tax increase. Similar arguments. The Fairness Project, again, that California-based group, invested $3.5 million in this campaign, which was that was $3.5 million out of $3.8 million spent on the campaign. Almost all came from this organization, and they prevailed. So the one loss was Montana. Democratic governor was pushing it. They actually already had expanded Medicaid, but they expanded Medicaid with a sunset, which is going to occur later this year. And they said if it's going to go further, we need an initiative, and we need to pay for the expansion. And they put a $2 per pack tobacco tax on the Montana ballot. So what happened here is, while in the other states, Fairness Project and others ensured the yes side was the dominant side in terms of ads and funding, in Montana, the tobacco industry spent $17 million, which is a phenomenal amount of money for a state the size of Montana, and they outspent the proponents massively, and it lost. So Idaho and Nebraska are moving ahead to implement the plan. In Utah, the legislature is somewhat resistant. They're looking for ways to make it more difficult. Montana is trying to figure out a way to keep their expansion in place. So that's the update on the red states. I can maybe pause for a moment there, Mr. Chair, before the next topic to see if you have any questions.
I think what I'm going to do is ask you to, let's call it a wrap there.
Okay.
Hold off on responding to other questions until our next meeting, but please save that thought. Thank you for that report back, because I really do think it's helpful in thinking through where we go from here. So it wasn't just idle curiosity or interest in the political process that prompted the question. It was desire on my part to think about where we go from here. But given the fact that we have a few more of our reports to get to, I want to just wrap it there. Thank you. As always, a very thorough and clearly shared presentation. Let me just ask Supervisor Ellenberg if she has any questions or comments at this point.
I don't. Thank you.
All right. Then I'm going to say thank you very much. Look forward to working with you this year.
Thank you.
All right. That takes us to the report on 6D, Santa Clara Valley Medical Center.
Thank you, Chair Simidian, Supervisor Ellenberg. I first want to start out by acknowledging the good work of staff. Recently, Valley Medical Center was acknowledged as a baby-friendly hospital. This is an acknowledgement and recognition issued by the World Health Organization. There are only 553 hospitals in the nation that have this designation out of over 5,000 hospitals. So this is something that we're very proud of. The initiative recognizes hospitals and around our optimal care for breastfeeding mothers and their babies, which encourages, of course, maternal-infant bonding.
I'm sorry to interrupt, Paul, but if you've got a press release or information on that, I would love to see it.
We would love to share that with you.
Happy to promote it as well. That's exciting.
This was an undertaking that has taken a number of years because obviously it's a multidisciplinary approach in care that involves all disciplines, but also inpatient and outpatient services. So this is something that we're very proud of and once again acknowledges the good work of staff and the commitment we have to our patients around patient-centered care. I want to just give a brief overview in terms of what's going on with Valley Medical Center, then briefly also touch on the transition work that has been occurring in preparation for the two hospitals. First, the patient days at Valley Medical Center compared to prior year are slightly down. It's about 1.3%, but there's a number of reasons for that. First of all, there's been good work by staff in reducing the number of non-acute patients in the hospital. So that, of course, affects the patient days compared to prior year. We have seen an increase in demand in our medical surgical units, our intensive care units for adults, and our telemetry units. That, of course, has been offset by some decrease in the area of maternal child health, and I'm speaking primarily in the area of pediatrics and deliveries, OB. But clearly, what we're seeing and trending is the increasing need and demand for beds in both the medical surgical area, but also in the adult intensive care units in this county. In the area of outpatient services, compared to prior year, we have about a 12% increase in primary care visits. So that does give some signal with respect to our ability to continue to provide and improve access to patients in that area. With respect to specialty, we are also seeing in a number of different specialties an increase in the utilization of services. In many of those areas, we are impacted and are looking at strategies to further improve access by increasing the available providers within those service units. But overall, Valley Medical Center continues to improve in the area of access. The limiting factor, of course, is our capacity, which brings me to the two hospitals. So while there's been much discussion and work, incredible work done in terms of moving to acquire the two hospitals, Dr. Smith has been very clear that our effort and our focus from an operating standpoint is to prepare for that transition. So of course we're looking towards the end of February, the beginning of March to transfer ownership to the county. And I just want to highlight a few things that have been going on. First of all, there have been a number of work groups or work streams, as we're calling them, and they range everywhere from the clinical operations to finance to quality and safety to the medical staff, technology, facilities, human resources, and a number of others. The amount of work and the commitment by staff, given all their other responsibilities, has been phenomenal. We are on track to ensure that we move to a seamless transition so that we do not impact patient care. There are a couple things that we are focused on to ensure that smooth transition. The most important priority that we're focused on, of course, is a transition of staff from their current employment to county employment. The Employment Services Agency, as Jeff has alluded to, Dr. Smith has alluded to, has done a phenomenal job. To date, we have received over 2,000 applications, which is actually more than the number of employees that are currently at the two facilities. They have already issued offer letters in the realm of 600 plus to the employees, and that will continue this week. And we fully expect that that in the end, employees at the two hospitals will have something to respond to. And this has probably been the most difficult part of engaging these two hospitals. As you can imagine, the workforce at these two hospitals are critically important for us to sustain and operate the two facilities. And this is very personal to them, as you can imagine. So we're doing everything possible to have employee forums, interact with staff, be responsive as we can to ensure that they understand what the county's plans are and how we hope to mitigate and address many of their concerns going forward. The other areas that I just do want to touch on that are challenging given the process and also present risks. And I want to assure you that we are focused and we have work plans and we're clearly identifying those areas that we have to pay special attention to. So, of course, beyond the staffing at the two hospitals, the physician staffing and coverage, making sure that we have all the critical services covered, has been underway. Dr. Phuong Nguyen, Dr. Jennifer Tong, and others in medical leadership have done an excellent job in reaching out to the physicians in the community to assure them that they can maintain their practices and continue to use both O'Connor Hospital and St. Louis hospitals as their preferred facilities. The other work that's underway is around reviewing all the capital needs of the two facilities to ensure that we can continue to provide safe, quality care on day one when the county assumes responsibilities for these two facilities, because our goal is not to only provide access, but to provide quality care for our patients at the two facilities. The other thing that we are doing, and because these three hospitals will be operated under one license, and Dr. Smith has spoken to the importance of that from a financial viability standpoint, but it's really important that we further integrate and make sure that patients are utilizing the resources the county has to offer, meaning that the three hospitals have to work together to ensure that we are leveraging each other's expertise and capacity. And so we're working very closely with the two hospitals in addition to VMC to ensure that we have the ability to transfer and manage the patients within our system to minimize the amount of cost the county incurs with other facilities. We have the capacity, we have the expertise, we need to utilize that resource that we now have within our means. And finally, I would say that one of the most critical factors that we have identified going forward, and something that affects everything from clinical documentation to revenue cycle to how we're able to report and analyze and improve care, is the electronic health record. So Dr. Smith in the county exec's office has made it very clear that this is something that's critical and that we need to have in place as soon as possible. And with that in mind, we have established a tentative date of the end of June to go live with Epic. And that's an aggressive schedule, but it's something that I think all of us appreciate that will make a huge difference for us to stabilize the two hospitals and continue to provide the services we need to provide in the communities that we're obligated to. So that gives you some idea of some of the work that has been underway. And we would be happy, Supervisor Simitian, to give regular updates to this committee.
Thank you. Well, I hope the questions will be quick. I don't know if the answers will be. But before I get to the questions, just you won't be surprised that on the issue of the electronic health records, I have just three things I want to make sure that I ask you to stay sensitive to, and that's privacy, privacy, and privacy. And I think we've been doing a increasingly better job over the years that I've been here on focusing on these issues. I'm not in the field, so I don't know whether or not they're being realized in the work of the organization, but I at least get a sense that that there's a greater attention to the concern about the issue of patient privacy. I'm anxious that as we do anything quickly and aggressively, which we need to do, I got that, that privacy not be left behind in the conversation. So I'm laying that out for the team today as a subject that I'm going to want to revisit with you as we make progress on electronic health records. And I would also say, if we come up short in that effort, it will undermine the public confidence and trust that we need to make a 3-hospital system a success. So I'll let it go at that. Then I do, however, want to ask that in working with my staff and looking back at some of the prior statements, net income looked to be unfavorable to budget by $5.7 million in this past month, and that year to date we were looking at $59 million unfavorable to budget. Am I reading those numbers right? In given the assistance from my staff and burrowing through some of the documents.
Yes, Chairman, those are what were reported in November. Most of that is from when we did the November statements. We didn't have notice that we would get QIP and EPP reimbursement. We have a preprint letter from CMS that says those programs are approved, and we'll record a year-to-date catch-up in January. So you'll see another month of, fairly unfavorable numbers to be offset in January. We also have a couple of other items we'll be recording in January, which will change the picture fairly significantly.
Then looking not at dollars, but at patients, another key metric is our average daily census, and Ms. Lorenz, you were helpful in schooling me on why that number is important. I hope you don't regret the fact that you helped school me on that. But I note that we're 7% below budget, I believe, this last month, and I'm just curious, it's a month, but particularly since we've been talking about acquiring 2 new hospitals to meet the demand, which I have supported and continue to support, I just want to know if that's an indicator that should make me anxious, and if not, why not?
So thank you, Supervisor. So there are a couple things that you should know about the ADC. One, it depends on what unit you're speaking of. So my comments earlier with regards to ICU, medical surgical, telemetry, so those are services that these 2 hospitals will help mitigate and help manage in terms of the total patient population in need. We are seeing the decrease in the area of maternal child health, so in pediatrics, but also in deliveries, which is following the county-wide trend of births. So although we're maintaining our market share with regards to respect to births, countywide, with respect to countywide, we are seeing a decline in those census days, as you point out.
Okay, thank you. Ms. Ellenberg, comments or questions on this part of the report?
Yes, and it's certainly a challenge to work through these statements for the first time. I do see that the cash balance increased by $78.8 million to $173 million at October due to the global payment program. And so I'm wondering first why that balance maybe isn't used to offset some of the other losses. And once you've accounted for the QIP and EEP funding, you mentioned that the budget will be trued up a little bit. Will it be balanced? Will we still have a negative impact?
By itself, the QIP and EPP revenue wouldn't balance, but we have a prior period adjustment, which is very significant, that will be recorded in January, which will bring us to a balanced situation.
And the large cash?
The cash is somewhat irregular. A lot of the waiver programs we get paid on a quarterly basis, or we get paid when we complete reports. And the GPP payment, I believe, is quarterly, and it's the result of filing that quarterly report. We include the revenue in our statements on a monthly basis because the enterprise fund statements are accrual statements. So as we earn the revenue, we record it, and the receipt of the cash doesn't impact the bottom line revenue.
Got it. Thank you. I also just want to take this opportunity to recognize the tremendous work, Paul, that you and your team are doing, and Jeff isn't there, the invisible Dr. Smith. Moving us toward the transition to these hospitals is clearly a colossal effort, and I am really duly impressed by the amount of work that has already gone into this, by the organization and the anticipation of so many of the challenges that are coming our way, doing all of this in the face of the distraction presented by the Attorney General, and the goal of seamlessly moving without disrupting any patient care on the day that the sale closes is really just a tremendous effort, and I think our county will owe your team a great debt of gratitude, so thank you for that.
Thank you for giving us this opportunity.
All right, thank you. That takes us to 6E, which is to receive the report from Behavioral Health Services Department. But before we revisit, we do have cards from 3 speakers, so I'm going to ask Mario Gonzalez Brito, I believe it is, and Thomas Warner and Alyssa Koff-Ginsborg come forward. They have cards on 6E, so come on up.
Can I defer to the other speakers first, please?
Sure, I think I can keep track of 3 different people. That we can make that work. We're going to ask clerk to take that document. Thank you.
Thank you very much.
Welcome.
Hello, my name is Tomas Warner. I'm a licensed psychiatric technician at East Valley Behavioral Health. I'm here to speak on behalf of the patients, Madam Chairman, and people of the board. This is based on how come. How come I have to leave the clinic? How come I have to go to my home base? How come I can't stay with my doctor that I have been for years? How come I can't talk to a licensed social worker? When they go to the other clinics, they're not able to get their appointments, or it's delayed. Or if they go to their primary care, the primary care is not agreeing to write for specific medications. Let's say Ambien, something to help you sleep. When I have to talk to the patients on a basis of ground level, they're very distraught. They don't understand the rhymes or reasons as to the reason they're being forced out of the clinic. Some of the patients have to see 3 doctors in a span of 1 year because we don't keep doctors at our clinic. When the doctors do transfer the patients over, like I stated before, they're just refused or they're delayed. So the reason for how come is if you build a base of trust with your doctor, you want to keep that doctor and you should not be forced to be removed. Some patients have decided to stay and refuse to transfer, but a lot of them, they don't have that strength. They don't have that power to do so. We have no licensed social workers in our system. It's not in my scope of practice to do that, but it seems as though this is what I'm doing. And with the last bit of seconds that I had, because I thought I had 3 minutes, one patient came into my office one time and stated, I was going to kill myself, but I remember something that you had stated, and that is the reason I did not. And I had just randomly talked to that patient. That's frightening to me. That's all I have to say.
Thank you very much. Next speaker, please.
Good afternoon. I'm Elisa Koff-Ginsborg with the Behavioral Health Contractors Association. This report references the rate increase, and I'm here today to share the perspective of behavioral health providers who signed contracts in the days before October 1st that gave them increase in rates retroactive to July. I'm pleased to report that providers saw an immediate benefit to retaining staff because staff were aware this was potentially coming, and they were able to be told you'll be getting retroactive for the work you've done this year. We're beginning to see an impact on recruitment, which is the other goal. Providers, as you know, if you put a job announcement out with a raised salary at the beginning of October, it takes a couple months to recruit, to try to hire, and then it's the holidays and people don't want to start. But since January, providers have reported improvement in their hiring and reduction in their vacancy rates. So I look forward to being back here talking about full implementation and the impact of the rate increase. Thank you.
Thank you for your comments. And I believe this next speaker is our final speaker on this item.
Good afternoon, members of the board and my colleagues on the other side. It's a rarity for SEMA to come to the Health and Hospital Committees. It's even rarer that we're on the same page with our colleagues at SEIU, but we are today. Our major concern has been in a lack of robust conversation when it comes to the implementation of an integration plan with behavioral health. We are happy to report, we got a call late this morning that there is a willingness from county executive to help us shepherd this process along a little bit further. Our major concern is for a premature announcement of a complete merger without having had fully exhausted the process of a meet and confer. Both SEIU and SEMA have shared concerns that we haven't had a very transparent and robust conversation. When we've raised issues, we haven't been given sufficient enough information. We haven't been received a written narrative as we requested. But I am saying that right now SEIU and SEMA are working together to hopefully make sure that our community's needs, our patients, our clients are addressed in this merger. We support the idea of integration. We wholeheartedly believe it's a fundamental part of the healthcare system. We just want to make sure that the providers who work for the county, the managers who have to implement the program, the line staff all agree. We just have to be on the same page, and there has to be clear, precise benchmarks, action steps, and a movement forward. Thank you so much.
Thank you. And before you step away, I know you know what you mean, and I know we know what you mean, but just for those who may not know what you mean, when the word merger gets used in this context, it is not about the two hospitals. It is about our behavioral health services department and the merger creating that organization.
That is correct.
Great. Thank you. Just for the record, and keep everybody straight about which merger we're talking about. Ms. Tullies, I saw you leaning out, not in, given your earlier report. Do you have anything else you would like to add under 6E today? It's up to you, ma'am.
No, I think there'll be an off agenda that will talk about the primary care integration that had been requested by Supervisor Yeager, and it's probably going to be in your inbox when you go back to your offices. And I think I've kind of covered behavioral health.
We covered a lot of ground. Thank you for that. That takes us to 6F, to receive the verbal report from the health officer. Dr. Cody.
Yes, good afternoon. Given the time, I'm going to keep my comments very brief. I'll just want to assure you that there are no public health emergencies of note currently in the county. Flu season is light.
People are chuckling, but there was a time when she couldn't say that for a great many months, in all seriousness. So
I look forward to sharing more about the department at future HHCs.
Thank you very much. And that takes us to 6G, which is to receive the report from the Valley Health Plan.
Thank you, Supervisor Simidian and Supervisor Ellenberg. I will focus my comments on a few updates to the written report, which was submitted earlier in the cycle. We spoke about Medi-Cal enrollment earlier, and we will certainly continue to monitor that very closely. Again, there is a possibility that we may be seeing a leveling off of the negative trend, but it's a little bit too early to call. Uncovered California, our final results from the open enrollment are still coming in. We have a little bit under 15,000 members, Covered California members who have both enrolled and their premium payment has come through. We have a little under 19,000 members who have enrolled. So there's a gap, which is normal as premiums come through, and sometimes people enroll and the premiums never materialize, so they fall off. So we can peg our growth at somewhere between 20% and 50% for this open enrollment, depending on how those premium payments end up turning out. We don't know what might have been if the individual mandate had not disappeared, but we're encouraged that we did better than covered California overall. We gained market share within our region again against all of our competitors, including Kaiser. So we remain the number 2 health plan, but we're a little bit closer, just a little bit closer to number 1 than we were before. And I often think, Supervisor Simitian, of your direction. I think it was the day after the last presidential election when we were all saying, well, what are we going to do about ACA, and your advice was to dam the torpedoes, full speed ahead. That's what we've been doing. That's what we've continued with all along, and it's paying off for us.
Well, thank you for that report, and let me just say I've thought of that moment many times over the last 2 years, given the peaks and valleys of the discussion about healthcare in the country. I do want to acknowledge I've also at various times expressed, I think, some concern, maybe even skepticism about the ability of to get the covered California numbers to a place that was sustainable, and I think you're clearly there. So I just want to acknowledge you've got me, at least for a week or two, less anxious about that. And in all seriousness, you're feeling like that is the 16,181 enrolled members is a decent-sized pool for our purposes, yes?
Yeah, definitely.
Okay, good.
Definitely.
Supervisor Ellenberg?
More is bigger.
More is better, right. Supervisor Ellenberg?
No comments on this item. Thank you.
All right. Then I believe that since we've approved our consent calendar earlier, and that was items 7 through 13, that takes us to item number 14, which is our adjournment to the next regular meeting on Thursday, February the 28th at 2 p.m. in these board chambers. Without objection, we stand adjourned. Thank you all very much. Look forward to it.